Okay, hello lovely people. We are going to get started with our week 7 content. So we'll start off with the clinical skills. So we're starting off with the examination of gait and sensory system. Nice and short one for this week because it's not as high yield as your other CLIN skills topics, but it's good to just go through anyway. So next slide, please. Yeah, okay, so when you're having a look at gait examination, it's always good to just start off by examining just how they walk normally. The best way to look at this for your patient is when they're actually just entering the room. Always good to just do an examination of this, keep it in the back of your mind, and don't just focus on their legs, but the whole body, because even if someone is able to compensate and appear to walk normally, they could be in pain, they could be, very concentrated on how they're walking, they could be having some difficulty with their movements elsewhere. So just look at the whole person overall. In terms of the actual specific examination, your next step here would be to be examining tandem gait, so checking if the person is able to walk heel to toe in a straight line. The next thing would be to test how they're able to walk on their heels, how they're able to walk on their toes. So when we're examining walking on their heels, we are looking at their calf muscles specifically. And when we're focusing on how they walk on their toes, we're testing anterior tibial function there. The next step would be testing how the person is able to rise from a squat. So just get the person to do a normal squat. If you feel like there's a bit of inconsistency or you're a bit unsure, get them to do it a couple of times. And then the fifth thing that we have here is the Romberg's test. So the patient is going to stand feet together, hands by their side, close their eyes, just standing still. And a positive test for Romberg's test is if the patient starts to tip over or fall, that means they have impaired proprioception in the legs. So that's a positive test for Romberg's. Just next slide, thanks. Yeah. Okay, so now we're talking about patterns of gait disorders. So these are some things to look out for. So the first thing would be something we call spastic gait, where the patient has stiff legs due to the interruption in the corticospinal or the pyramidal tracts. And don't worry, we'll talk a little bit more about those tracts later on. The next thing is Parkinsonian. So the patient has very slow shuffling due to extrapyramidal problems. The next thing is ataxic. An ataxic gait disorder where there's incoordination or they're unbalanced due to problems with the cerebellum. Cerebellum we've talked about a lot in some previous presentations we've done. So have a look there at previous week's slides if you're a bit confused. The next thing is apraxic gait disorders. So there's a loss of skilled movement. So usually the patient is able to, they have normal coordination otherwise, but then in terms of taking a step or something like that, they're having a bit of difficulty with that. They're having loss of that movement. The next thing is foot slapping and high stepping are very closely linked. So foot slapping is where there's a difficulty or a problem rather with the CNS or the PNS. And so the patient is having foot drops, so their foot drops. Quite simple like that. And then and of course for foot slapping, that's because their foot is hitting the ground. And then high stepping is the patient to kind of compensate for the fact that their foot is now, instead of like this, it's like this, they are stepping higher than average. And you can see them focusing on stepping higher because they're trying to make sure that their foot doesn't slap on the ground. So those two are very closely linked. The next thing to look out for is waddling. You can imagine what waddling looks like, and that's due to proximal muscle weakness. So that would be higher up in the legs. The next thing is antalgic. So that's just, you can observe that they're having a lot of pain when they're walking, or they tell you they have painful gait. The next thing is mechanical. So if the movements appear mechanical to you, and that would be evident in something like hip arthritis. And the last one here is psychogenic or hysterical gait disorders. So these are the ones that are a little, don't really fit into the other categories. For example, it might be something like a conversion disorder. For any of you who have seen Never Have I Ever on Netflix, the main character there, she goes through a traumatic event. She watches her dad pass away. And because of that trauma, her legs just stop working. So she has to use a wheelchair temporarily. So that's what a conversion disorder is where a patient goes through something more psychological, a real life sort of trauma, and they lose function or they lose movement in a part of their body. And it's not really explainable through a physical injury that's happened to them. So yeah, that's the last category there. These are all just different things to look out for. Next slide, thank you. Yep, and just quickly going over two very important lower limb peripheral nerves. So the first one is the common peroneal nerve, and you can see that in the first picture that's there. So if you, well, first of all, the common peroneal nerve is at the knee level, and you can see it very prominent there next to the fibular head. That's where we always like to direct our attention to when we're observing for a problem. And if there's a problem there, so say, for example, you have a broken fibula, like in that diagram there, and then that can affect the common peroneal nerve. So the common peroneal nerve has both motor and sensory problems that can come from damage to that. So in terms of motor, you can see things like foot drop, weakness of the ankle, toe dorsiflexion, and foot eversion. And in terms of sensory issues you may have sensory loss at the dorsum of the foot and the lateral aspect of the lower leg. So these are all things to look out for. And the second really important one is the lateral femoral cutaneous nerve. And so when we're having a look at that, we're looking for it at the pelvis level near the ACEs. And you can see in that diagram there as well, if there's ever an issue. This is, we're not really talking about motor here for this one, it's more the sensory. And if you have a problem, as you can see in this diagram where it says affected area of thigh. So when you're having an issue with the lateral femoral cutaneous nerve, so like damage to that nerve, you may have sensory loss in the lateral part of the thigh, as you can see in that diagram there. Yep, and next one. Yeah, and this is just a little bit about the sensory nervous system here. So these are a few of the main sort of pathways that we're going to be talking about. So the first one is the dorsal column pathway. If we remember from last week's topics, we were talking about different things to look out for. It was related to upper limb in last week's topic, but of course it's still related to lower limb and all throughout the body. So some of the different things we were testing for include like proprioception and vibration. So proprioception and vibration, as you can see here, they're linked to the dorsal column pathway specifically. So if you have a lesion within that pathway, that can cause sensory ataxia, unsteadiness, and impaired sensation. And the Romberg sign that we were talking about, where the patient's kind of falling when their eyes are closed and they're standing still, that will be positive if you have an issue with that pathway. The next thing to focus on here is the spinothalamic pathway. So another two things we were testing were pain and temperature in a general examination of one of the limbs. And if you have an issue with the spinothalamic pathway, those are the things you're going to be affecting, because this is the sensation where you have like, if there's a lesion there, it can cause numbness, paresthesia, nerve pain. So it's very much linked to pain and temperature specifically. And the last thing we're talking about here is cortical sensation. So in this pathway, we're talking about things like proprioception, sturgeonosis. If we remember from last week's session, sturgeonosis was being able to recognize the type of object that a patient has in their hand when their eyes are closed. And yeah, so if we have a lesion in this area, it causes neglect. So it's neglecting one side of the body. So a problem you may have with this is you might see a loss of sensation, or they're not able to recognize an object in one hand in comparison to the other where they're still able to do that. And that's just because if you have a lesion in this area, the body likes to focus all of its energy on the side that doesn't have the problem, because it's like, oh goodness, okay, we're struggling, we have a problem on this side, let's just try and make sure the other side stays stable. So that's kind of the idea of it neglects the side that's been affected. And yeah, just on the last slide, that's just the dorsal column pathway and the spinothalamic pathway, just for you to have a look at in your own time. Again, all of this content we've just gone through, it's not as high yield as some of the other CLIN skills topics you'll do, but it's good to just have a bit of revision, go through these slides when you're in your revision stage. And yeah, as always, if you have any questions, feel free to text me on Facebook or email me.
Okay, so I'm going to be covering outbreak investigation today, and this is I'm going to introduce some new concepts, and I've highlighted which slides are high yield, and I've also highlighted on the slides where I can't fit sort of the extra information. They're all in speaker notes. Okay, so outbreak. An outbreak is when we have more cases than expected of a particular disease among a specific group of people in a given area or over a particular period of time. And some good definitions to know would be an epidemic or an outbreak is when you have more cases than usual. An outbreak may be less cases or in a smaller area or a smaller population, but they're fairly similar, epidemic and outbreak. And then if you take an epidemic into a world scale, you get a pandemic. And then there's also cluster. Wait, am I recording? Yeah, I'm recording. Okay.
Yeah, all
Then
good.
there's cluster. Thanks, Natania. There's cluster, which is a group or aggregation of cases, and then an endemic, where there's a permanent or regular disease incidence. So this is something that's quite high yield. It's a disease natural history timeline, and you've got latent period going into infectious period. That means the top row is when someone is not infectious but becomes infectious. And on the bottom row, it's when someone is not symptomatic becomes symptomatic. And it's very dangerous when you've got someone who is infectious before they're symptomatic. And this is one of the reasons why COVID was so hard to control, because people were infectious and they were spreading it to other people before they showed signs so that they would go get tested. This would be something worth memorizing. An example of an exam question would be they'd cross out, for example, incubation period, and then they'd ask, like, out of the 4 options below, which one is the right one that would be in the, like, that, which one is missing. So know this image. Sources of outbreaks. So there are 3 sources of outbreaks. One, you've got new appearance of an infectious agent or toxic material from the environment or infected source. So that could be international travel going into the country. 2, it's not the disease that's coming in, but it's susceptible people who are coming in. So people who are immunocompromised coming into a certain area, or people who have never been exposed come to an area and then are exposed. And the third one is introduction of effective route of transmission from source to susceptible people. An example of this is climate change, and climate change results in changes in temperature, possibly changes in the migration of mosquitoes or natural selection. And so because of that, we've got an introduction of new mosquito species, and then that has resulted in changes or outbreaks in diseases associated with mosquitoes. So what do we do? 3 things. 1, we identify the pathogen or source. 2, we control and stop new cases. And 3, we prevent future outbreaks. And this happens simultaneously with learning more about the disease, investing into R&D into diseases, as well as training people to manage and prevent diseases. Another high yield slide is this one, steps of an outbreak investigation. And there are 10. So let's go through them. The lecture will go through them in great detail, but I'll just run through them so you have a gist of what the lecture is going to say this week. So 1, prepare for field work. We go out into the field to investigate the risk factors and causes of an outbreak. So we want to know, well, from a field work, we want to investigate, okay, what's the cause of this? Is it structural? Has there been a breakdown of health infrastructure? For example, is water now contaminated, which results in this, results in an outbreak? And who will we take with us in our team? So what skills do we need out in the field? Who are we going to bring with us? And what do we need to bring with us? That's preparing for field work. 2, verify, establish the existence of the outbreak. So we need to have tangible data. Do we have access to a baseline or what's usual data so that we can compare it to the data from the outbreak? And is it coincidental? Is it a coincidence that a specific number of people in this area all have gastro, or is there a cause and are they actually related to each other? So to do that, you'd have to identify, okay, did they all go to the same event? Did they all get their food from the same restaurant or the same grocery store? And do we wait for reports to come in, which is passive, or do we go look for the existence of an outbreak by actively testing things? For example, in hospitals, we have a huge problem with Staphylococcus aureus, but it's resistant to the main antibiotic that is used to fight against it, which is methicillin. And so we call that methicillin-resistant Staphylococcus aureus, MRSA. And so we would actively identify MRSA, and do we conduct surveillance to detect earlier trends before they happen? 3, confirm and verify the diagnosis. So what is the strain of the bacteria or the virus that is causing this outbreak? 4, define and identify cases. So a case definition, for example, who we determine as someone who has been affected by this outbreak or who has this disease, is that there's a standard set of criteria for deciding whether or not an individual should be classified as having the health condition of interest. And so, for example, that might be all of the cases would have to present with bloody diarrhea, for example. 5, describe and orient data, person, place, or time. I've got lots of slides coming up to develop this more. 6, 7, 8, 9, 10 are a little bit more intuitive. Develop your hypotheses, evaluate it, refine it as you perform additional studies. 9, implement control and prevention measures. So this would be things on a large national scales like TV ads to stop doing whatever, or on a local scale so that GPs can take preventative measures. And 10, communicate findings, simply because there's no point in investigating all of this if you can't share it with the community around you so that we can control outbreaks. So we've got a couple slides coming up that are quite high yield. So this is a comparison of 2 of the epidemiology curves that we have to know. The left one is called a common point source outbreak. And this makes sense because here, approximately day 17 on the left, there's a spike. And then so before that, there's quite a steep increase. And then there's a relatively less steep down slope. But there's only one outbreak. And an example of this is hepatitis A. If they are able to control it, then it goes down. On the other hand, there's a continuous extended source epidemic, and continuous extended source outbreaks will produce a curve with a sharp upspring. So that tells us like really infectious, followed by a plateau. Okay, so if it's not responding to any treatment or it's spreading too quickly in the community. And then eventually when it does respond to treatment and containment procedures, then there's a right tail. An example of this is cholera. And in the PowerPoint, I've left a comment highlighting cholera for you to comment on my comment and tell me what your guesses are as to why cholera would be an example of a continuous extended source epidemic. Third one is the propagated or progressive outbreak. So here we're seeing spikes, and every time there's a spike, the succeeding spike is higher than the preceding spike. So this disease is transmitted from person to person, leading to serial transmission. The curve classically should have a series of progressively taller peaks, one incubation period apart. For example, measles. So during the spikes, where there's the one incubation period, people are becoming infectious, or they're becoming infectious, but then they haven't shown the signs yet. Another really high yield slide is this one, and we are going to be comparing case control studies to cohort studies. So what happens here, if you have a look, is that in the case control study, time is going forwards, but the direction of the study is going backwards. When we say the direction of the study is going backwards, we are saying we are taking a group of people who may already have the illness, and then we're looking back to see whether or not they were exposed to something. That means that we are looking back in time. And reasons why we look back in time is, one, it could be cheaper because you don't have to follow people, you don't have to pay money or pay people to follow people, but you can just use registers of information. And on the other hand, when you have time going in the same direction as, this should say direction of inquiry, we are following people as they live their life. So this will take a lot longer, but it gives us a better glimpse or a better understanding of whether or not the exposure results in the disease. Let's break down this table a little bit So on the left-hand side, case control study, we are examining a small population group over a short period of time. It's less cost intensive and evaluates the association between multiple exposures and one outcome. An example of this would be people who have like a specific eye disease, and they want that's the one outcome. And then they want to see, okay, was this person exposed to like more than 5 hours of some UV light per day or something like that? And then you'd be able to map out a list of exposures and whether or not they are associated, not necessarily causing, because we don't know that, because this is the direction of studies going backwards, but we do get an idea of what kind of exposures cause this disease. And the reason why I'm sharing this with you, or the reason why this is high yield for you, not only for your exams, but you will have to do an assignment on this, and you will have to know how to draw these diagrams too, depending on the assignment that you're given. So it's a good idea to have a grasp of it as soon as you can, because then the tutorials are a lot easier and the assignment is a lot easier too. In the case control study, the study sample is selected according to whether a person has a disease or doesn't, and then it is determined which participants were exposed to a risk factor. In the tutorials, there's an example where they collected all these teens with depression, and then they looked back to see if they'd smoked weed in the past, and then comparing the people who are exposed and people who are not exposed, they were able to get some idea of if there's a correlation. In cohort study, we're examining a large population over a long period of time, more cost intensive because more laborious, and determines how one exposure is associated with multiple outcomes. So here with one exposure, it's either exposed or unexposed, and then we're going to see if this person becomes diseased or not. The study sample is selected based on exposure to a risk factor. And this, while it takes longer, it's much more accurate because we have a better understanding that it's not just correlation, but could be causation too. Odds ratio. Odds ratio is a measure of association between an exposure and an outcome. And so to do this, we would have a look on the right, A divided by C, meaning exposed, all the people who have the cases, those who are exposed, divided by the people with the cases who are unexposed, and then divide all of that by the people who were not cases but were exposed, and divide that by the people who were not cases but unexposed, meaning A divided by C, all divided by B over D. And then if you mix the math up or do the math, then it becomes A over AD divided by BC. This is something you'll need to know. It's probably going to be an exam, like what's the OR? And the OR here means the odds of disease in the exposed group divided by odds of disease in the unexposed group.
So viral pathogenesis 1 and 2, these are two separate lectures, but we're just going to combine them into one because they follow straight on from the other. So the learning outcomes for this are recalling viral structures and obligate intracellular life cycles, recall transmission of viral infections, describe the major outcomes of viral infection, describe how viruses are classified by their characteristics and the Baltimore classification system, define and order the key steps in the viral life cycle, give examples of the pathogenesis of some important DNA and RNA human viruses. So just a recap, this should all be stuff that you've covered before, but basically viruses are acellular, obligate intracellular parasites. So that just means that they're non-living. Obligate intracellular parasites means that they have to be inside other cells to survive. So they are essentially the definition of a parasite because they leech off another cell's resources. This means that they're not alive and need host cells to survive. They can only replicate within host cells, so they can't reproduce on a surface like bacteria can. Viruses can infect bacteria, archaea, plants, fungi, insects, and animals, and they have small viral genomes with high genetic diversity. So to the right, we have a diagram. of a virus. I believe that this is the HIV virus, just as an example. So it can either be enveloped or naked. This one is an enveloped virus. You can see that outer yellow circle. The virion contains the genome, which is surrounded by a protein capsid. So that's the internal part of the virus. So you can see that the red strands of RNA, that will contain the genome. This one also has reverse transcriptase enzymes. We'll go into why it has that in the later slide. And then the protein capsid is the purple part, which just protects it and surrounds it all. And then, yeah, like I said, this is the HIV virus, and it has an additional lipid envelope. And this envelope is embedded with viral glycoproteins. So those are the purple bits sticking out of it. So that's just a pretty generic virus structure. Transmission of viruses, this one, this slide comes directly from the lectures. It's pretty much common sense. If you just think about ways that viruses can be transmitted, you should be able to come up with all of those. Stages of viral replication. So you have 6 main stages. Essentially, stage 1, attachment. The influenza virus or whichever virus it is will enter the cell. And different viruses have different ways of entering. Most of them have surface proteins which help them unlock and enter the cell. Penetration is when the cell engulfs the virus by endocytosis. So that's how it becomes part of the cell and it's in a little vesicle. Uncoating is when the viral contents are released, so it fully infiltrates the cell. Then we have biosynthesis, where viral RNA enters the nucleus to be replicated by viral RNA polymerase. Assembly, new phage particles are assembled, so that's when it's making new viruses out of the copies of DNA or RNA that it's just made. And then release, so new viral particles are made and released into the extracellular fluid. The cell, which is not killed in the process, continues to make new viruses. So that differs depending on the type of virus, but for influenza, the cell can just keep on going. What do viruses do to the body? So we've learned about what viruses are, but this is more about how do they actually make you sick. So there's a couple of different ways that this can occur. Firstly, we've got oncogenesis. So this is where a virus causes normal cells to transform into cancerous cells. This can be through activating oncogenes or inhibiting tumor suppressor genes. You might remember from some of the biochem lectures earlier this year, the different ways that cancer occurs. So that can be triggered by a virus. Cytopathy, that's where the virus causes host cells to die, which causes tissue damage. Immunopathology, that's where the host responds to infection. So that's things like inflammation. Basically, it's your immune system that's causing damage to the tissues rather than the virus itself. So it's a bit of an overreaction by your immune system in your body, and that's what's actually harming you. Persistent infection. So some viruses can evade the immune system and last in your body for a long time. And there's different strategies and ways of doing that, which we'll go into. And latent infection. So that's where the virus will lie dormant within cells without harming them. But then at a later stage, it'll re-emerge as a lytic infection. And that can be triggered by a range of different factors, which we will also go into. So those are kind of the main things that viruses can actually do to your body. Baltimore classification. So this is a classification system for viruses based on the type of nucleic acid they contain. That's either DNA or RNA. Their strandedness, so that's whether they're double or single stranded. Their sense, so that's whether they're positive or negative. We'll explain all of these shortly. And their method of replication. And so as you can see here, there's 7 different classes. You don't really need to worry about which class corresponds to which different characteristics. It's just important to know what the Baltimore classification is actually on the basis of. And so those are all of the different ways that viruses can vary from each other. So first we're going to talk about the group of DNA viruses, and there's just a few key examples that the lecturers want you to know. So those are the main ones that will come up in exams. HSV, so herpes simplex virus, is a double-stranded DNA virus. HSV type 1 is oral herpes and type 2 is genital herpes. It's transmitted via skin-to-skin contact with a lesion, so that's like an open sore that you have at the time. It causes latent infection in the host by inhibiting type 1 interferon responses, CD8 T cell and natural killer cell apoptosis. So basically it stops all of these different types of cells from killing it in an immune response. It also degrades MHC1 markers to avoid the CD8 T cell elimination. HSV1 stays in the trigeminal ganglia, while HSV2 remains in the sacral ganglia. So that's where it lies dormant while it's in the latent phase. And it cannot be transmitted while latent, only while reactivated. So even though it's a virus that you can't cure and that you will have for life, it's only infectious in certain periods. So it can't be transmitted all the time. Latency and reactivations. This is just a general note on these concepts. During latency, the virus remains within the nucleus of a cell. So it's not leaving the cell, it's only in an intracellular environment where it's contained. No infectious virus is produced. So like I was saying before, with herpes, for example, you can't catch it from someone unless it's actually active at the time. During reactivation, virion formation occurs and new viruses are released. And there's a few different things that can cause reactivation to occur. It's not just random. You've got cellular factors, UV light, stress, fever, immune suppression, and tissue damage. So basically when the body's already worn down, that's when these things will pop up. HPV, so that's human papillomavirus. It's a double-stranded DNA virus. There are over 170 different genotypes. It causes skin warts, which are initially benign or harmless, and genital warts, which may transform into cervical, penile, or throat cancers. It's transmitted via skin-to-skin contact or during childbirth from a mother to child. Viral proteins E6 and E7 inhibit tumour suppression proteins RB and P53, if you remember those from some of the cancer lectures. Those are your two key tumour suppressor proteins, which are like really commonly turned off in a lot of different types of cancers. This leads to uncontrolled tumour growth. It's not cytotoxic, so it doesn't cause inflammation. The way it impacts the body is through this oncogenesis. And malignancy takes years to develop, so you catch it and it doesn't cause a problem for a while. Next, we're going to focus on some of the main RNA viruses. So this is where it splits off into lecture 2, I believe. RNA viruses overview. So we've got positive sense RNA. This is where the sense classification comes in. So this type of RNA can be used directly as mRNA because it's obviously already RNA. So the body can use that to do translation and make proteins. Negative sense RNA is transcribed into its complement, which is then mRNA. So that's the difference. Negative sense RNA just has to go through one more stage before it can be used by the body. RNA viruses need their own RNA polymerase. So that's just an extra enzyme that you would find in the virion, which is used to transform the RNA. They have a higher mutation rate as there is no proofreading activity. So that just means that you'll have different mutated versions of the virus, and it sometimes makes it harder to develop immunity, vaccinations, that kind of thing. COVID-19, so this one's obviously very topical. It's a positive sense single-stranded RNA enveloped virus. Other coronaviruses can cause SARS and MERS. You might have heard of some of those. So it's within the same family. It causes inflammation in the lungs, which can cause fluid buildup. The host immune response also causes systemic effects. So it's immunopathology. It's where your immune system kind of mediates the damage to the body. It was first recognised in the human population in December 2019, as I'm sure you'd all be aware of, and there was no existing immunity, which is why it caused a pandemic. Hepatitis C, this is a positive sense single-stranded RNA enveloped virus. It's transmitted via the blood, so you can catch it from contaminated blood products, medical equipment, needle sharing, so that's especially within the IV drug user community, tattooing or childbirth from a mother to child. It infects hepatocytes in the liver and spontaneously mutates to avoid the immune system. So that's how it can become a chronic or persistent infection. The inflammatory response by the body causes fibrosis and cirrhosis to the liver. So it's really damaging to that organ, and it can go on to cause chronic disease and cancer. What is a retrovirus? So a retrovirus, they're kind of a subgroup of a positive sense single-stranded RNA viruses. But instead of using the RNA as mRNA directly, which is the way that positive sense RNA viruses usually work, first, this RNA is converted into double-stranded DNA. So reverse transcriptase is the enzyme, which you'll find in the virion, which converts RNA to DNA, so it can be integrated in the host genome. So if you remember from the diagram of HIV that we had, it has a reverse transcriptase enzyme because it's a retrovirus. So HIV, a positive sense single-stranded RNA retrovirus. It primarily infects and lyses CD4 plus T cells, so those are your T helper cells. It causes persistent infection, which eventually leads to AIDS if it's untreated. It's transmitted via the blood, sexual intercourse, and during childbirth or breastfeeding, so in lots of different bodily fluids. It can be treated with antiretroviral drugs to reduce the viral load to undetectable levels. So again, even though this is a virus that can't be cured and it will be with you for life if you catch it, nowadays, thanks to modern medicine, we can reduce the viral load so much that it's essentially as if you didn't have it, because when the virus is at undetectable loads, it can't be transmitted and it won't cause any symptoms. And it means that it won't progress to AIDS if it's managed well. So while HIV used to be kind of a death sentence because AIDS was inevitable, that's no longer the case. Yep, so like I'm saying, this has reduced the death rate of HIV. Influenza is another negative sense single-stranded RNA virus. This one, I'm sure you all know pretty much everything about it, that it infects the respiratory tract. Systemic symptoms are caused by the immune response by the body, and it's usually acute, which just means it's self-limiting, comes on suddenly, but it isn't going to become chronic for most people. It's usually a mild illness that doesn't last very long. Ebola, another negative sense single-stranded RNA enveloped virus. This one is transmitted with via contact with bodily fluids, so urine, saliva, and blood. It infects multiple systems and cell types. So whereas some of the other viruses have been contained to single organs or to the skin, things like that, this one affects multiple different organ systems within the body, and it causes systemic symptoms, cell lysis and host immunopathology. So it's got two different types of pathology. They can kill patients within 6 to 16 days of contracting the virus, and it also has an incubation period of 2 to 21 days. So this makes it pretty infectious because you won't know you have it necessarily for up to 3 weeks. So in that time, you might transmit it to a lot of other people. So that's how it causes mass infection. So that's pretty much all you need to know for viral pathogenesis. Now we've got infectious diseases of the musculoskeletal system and the skin. Learning objectives for this one are relate the 3 main mechanisms of how skin and soft tissue infections occur. So we've got breach, systemic infection, and toxin mediated. We'll go into those. Describe bone and joint infections. Appreciate that the majority of skin and musculoskeletal infections are caused by viruses and bacteria, but there can also be fungal and parasitic causes. Recognize the significance of the bacteria Streptococcus pyogenes and Staphylococcus aureus as important causes of many skin and MSK infections. So how do these MSK and skin diseases occur? So we've got 3 main ways that they can get into the body. We've got the breach of skin. So this can occur during surgery, in burns, cuts, IV drips. That's basically where you've got a physical wound in the skin, and that's how any of these different pathogens can access the skin. We've also got systemic infection. So this can be caused by Salmonella typhi, Neisseria meningitidis, herpes, and varicella. So those are some different examples of, you've got viruses and bacteria there which cause systemic infection, which then crosses into the skin and the MSK system, or toxin damage. So in things like scarlet fever or toxic shock syndrome, they produce toxins which are responsible for damaging the skin or the MSK system. Skin lines of defense. So the first line of defense is a physical barrier. This also is just taken directly from the lecture slides, I believe. So it's composed of the squamous epithelium. And basically the way this works is it forms firstly a physical barrier, and it keeps the body at a low temperature, which isn't ideal or suitable for most of the bacteria, viruses, etc. The next line is chemical. So this consists of your sweat. The sweat contains antimicrobial fatty acids, so they can damage some bacteria. Acidic pH, again, not the ideal pH, so it discourages bacteria, viruses, etc. Then finally, we've got the biological line of defense. So this consists of your normal flora. That's the bacteria that always live within your body. and they don't normally harm the body. So they compete for nutrients, and basically if they colonize your body first, it prevents other bacteria from entering and setting up camp. Infection sites. So this one isn't super important. I just chucked it in there for the sake of completeness, but this probably won't come up. So unless you want to be very thorough, this isn't as important to memorize. Types of skin lesions. Again, this is more low yield. So unless you're super interested in the different types of skin lesions, I don't think you'll necessarily be asked to differentiate between these ones. Types of infections. So these are the main ones that you need to know about. So for bacterial ones, we've got folliculitis, boils, and carbuncles. Impetigo, scalded skin syndrome, erysipelas, cellulitis, and acne. Viral, we've got rubella, measles, chickenpox or shingles, warts and herpes. Fungal, we've got tinea or candidiasis. Bacterial infections. So first we've got scalded skin syndrome. Just a photo to the right there, you can see why it's named scalded syndrome, because it looks like you've burnt the skin and the burn's now peeling. So it's caused by toxins from Staphylococcus aureus. It causes large areas of skin desquamation and blisters. So that just means where the skin's peeling. And it's treatable with fluid replacement and antibiotics. Next, we've got toxic shock syndrome. So that kind of looks a little bit similar. It's caused by exotoxins from Staphylococcus aureus or Streptococcus pyogenes. It's generally the most common cause you'll hear about is due to tampon use in the genital area, but it can also be non-genital. It affects multiple organs. It causes hypertension, fever, and widespread rash. It can be a medical emergency, but it is treatable with drainage, antibiotics, and fluid replacement. We've got scarlet fever. So this one has two very characteristic symptoms, like you can see in the photos. It's caused by exotoxins from Streptococcus pyogenes, causes a punctate erythematous rash and strawberry tongue. So the rash is very characteristic of scarlet fever. That one's on the left. And then strawberry tongue, you can see it kind of looks like the bumps on the outside of a strawberry. That's why it's called that. Cellulitis is caused by Staph aureus or Streptococcus pyogenes. You're probably noticing a bit of a pattern now, because these two are really the key bacteria that you'll find are responsible for many of these different infections. It involves the layer of subcutaneous tissue, and it causes red, swollen, shiny skin and a fever. So you can see the left foot is obviously a lot more inflamed compared to the right in that patient. Necrotizing fasciitis. This one's caused by Streptococcus pyogenes. It involves all of the skin layers. So that differentiates it from cellulitis, which was the subcutaneous tissue. Symptoms include purple skin necrosis and pain. So this one is very obvious. You can tell that that is dying flesh. Gas gangrene. This one is caused by Clostridium perfringens. So this one is actually different. It's not Staph aureus for once. It causes cellulitis, necrosis, and gas production and gangrene. So the main thing that makes this one different is that you can see those blisters that are filled up with gas. It's treatable with penicillin, however. Acne, I'm sure everyone is familiar with this one. It can be caused, among other factors, by Cutibacterium acnes. And essentially it's where the sebaceous ducts in the skin are blocked due to increased sebum production. Leprosy. So this one's caused by Mycobacterium leprae. And you've got two different types. There's tuberculoid leprosy, where there's a low number of organisms, but a high immune response, or lepromatous leprosy, where there's a high number of organisms, but no immune response. And that's just a picture there of what leprosy looks like. Now moving on to fungal infections. So candidiasis is caused by Candida albicans. It causes thrush, diaper rash, and oral candida. It is treatable with fluconazole or clotrimazole, which are two different antifungal drugs. That's what an example of oral thrush looks like on the tongue there. Dermatophytosis, this is a group that includes ringworm and tinea, and they're caused by dermatophytes, a type of fungus. The symptoms include a red and itchy rash. So that would be tinea, like on a foot there in that image. Viral infections. So varicella zoster So this is a virus that first causes chickenpox, and then if you catch it again later in life, it causes shingles. It's transmitted via respiratory droplets or skin lesion contact with like an active form of chickenpox. It is treatable with acyclovir, so that's an antiviral drug. Normally you won't need that just in childhood chickenpox. It's usually acute and self-limiting, but in vulnerable populations or where it is causing severe illness, that can be used. So if you've had chickenpox once in life, then it can reactivate as shingles, usually as like later in life as an adult. That's the main viral infection you needed to know. We already went into a bit about herpes earlier in the viral pathogenesis. Finally, we've got bone and joint infections. So osteomyelitis is caused again by Staph aureus in acute cases or Mycobacterium tuberculosis in chronic cases. So it's important to remember that differentiation. It most commonly affects the ends of long bones. It can be caught through open fractures or infection of soft tissue. Symptoms include pain, fever, and tenderness. Arthritis. Septic arthritis can be caused by Staph aureus, Salmonella, influenzae, or Neisseria gonorrhea. Viral arthritis can be caused by rubella, Zika virus, or chikungunya. Reactive arthritis can be caused by infections of the GIT. It is immune mediated where the pathogen is actually at a different site. So that means that the pathogen isn't actually infecting the joints, but the immune system is reacting and causing damage to the joints. Symptoms of arthritis include pain, stiffness, swelling, redness, and a decreased range of motion. Additionally, septic arthritis can cause a fever because that one causes the systemic symptoms. And that's everything from me. Thank you.